I'm Peggy Peck, MedPage Today. We're at the American Stroke Association's International Stroke Conference in Los Angeles, and I'm talking now with stroke neurologist Dr. Ralph Sacco, who interestingly enough is the president of the American Heart Association. So I always love to say that, Dr. Sacco, because I find it so interesting, a neurologist as president of the American Heart Association.
Stroke is important to the American Heart Association,
I know, vascular disease.
Okay.
It's all vascular. So first of all, I want to talk about this trial Avaros, which is a trial of an investigational anticoagulant. It is a factor Xa inhibitor.
Correct.
So these are new class of drugs we're looking at for patients that would be the same type of patients that would take warfarin.
Right.
So this particular trial is in patients who have atrial fibrillation, and the trial compares this drug, this investigational drug, to aspirin. The data were first reported at the European Society of Cardiology last fall. Now they're published in New England Journal, and they're reported here with some additional sub-analysis.
Right.
But my first question has to be, so this drug, one of these super new drugs, an oral anticoagulant, and it's being compared to aspirin, and does that surprise anybody that it would be better at preventing stroke than aspirin?
Well, it's not that surprising. We would hope it would be better than aspirin. And as you know, there is another trial, Aristotle, I believe is the name, that is comparing this drug to conventional oral anticoagulants with an INR of 2 to 3. I think the point, though, of the trial is there are certain people out there that are felt and deemed by physicians to not be good oral anticoagulant candidates. And that was the group that this trial was looking for. Those that physicians did not put on Coumadin or warfarin for whatever reasons, because they thought they had some exclusion criteria, those were eligible to be randomized to this new drug versus aspirin. And aspirin, as you know, is really the only other antiplatelet for people who can't take anticoagulants.
Mm-hmm. But I mean, what does that mean? Not good candidates for Coumadin?
Well, that's a good question. Some patients may have been on oral anticoagulants in the past and had bleeding issues. Some patients could have like an unstable gait and then could have a greater risk. Some patients may not have wanted to be on oral anticoagulants like warfarin because of the blood testing or other potential contraindications. But I think the point, I think it is true, not all of the contraindications to warfarin are clear. Some of them are more subjective than objective. We do know, though, the bottom line is that there are too few people treated with oral anticoagulants who have atrial fibrillation or at risk of stroke that we need to do something about.
Okay, fair enough. So they found in this trial, by the way, that apixaban was superior in terms of preventing stroke than aspirin, and there wasn't a big difference in bleeding risk. It didn't have excess bleeding events. What we haven't seen before is a sub-analysis of patients who had a prior stroke or TIA. And so what do we see in that?
This was an important subgroup because this trial was looking at a large group of atrial fibrillation patients where only a certain subgroup, and I think it was close to 700 and some, that had a prior stroke or TIA that were randomized into this trial. And that group usually has a higher risk. We know people who've already had a stroke or TIA are at even greater risk with non-valvular atrial fibrillation having a recurrent stroke. And they found very consistent effects in this small subgroup of a significant benefit of the new drug versus aspirin in the trial. And that was new information, I think, presented at the International Stroke Conference.
Mm-hmm. So that makes it, in a way, that gives it sort of a leg up, if you will, additional.
Right. Important. And so, the bleeding you raise is a good point. You know, remember, this drug is an anticoagulant, and it had similar risk of aspirin. That is actually a very interesting finding because we would have expected a bleeding risk even greater. Mm-hmm. And this bleeding risk was very non-significantly different than aspirin.
Mm-hmm. Mm-hmm. So well tolerated.
Well tolerated.
So far. So far. And we have to remind, it is investigational.
It is investigational, not yet FDA approved. Another big study out there that we'll be waiting for to know the results of.
So I want to move along to a discussion of the use of drugs that actually are approved. What I thought to be a very interesting paper reported today from researchers at the University of Michigan. And essentially what this said, it looked at the effect of the cost-related adherence problems for patients who had had a stroke. So these are patients who they've survived stroke and they're put on a number of medications post-stroke to prevent another stroke. And essentially what these researchers said is that that a lot of the non-adherence, and you yourself said that adherence is a big problem, has to do with money. People can't afford the drugs that they're put on. And the researcher, Dr. Levine from the University of Michigan, she said one of the points of this study, and by the way, the patients couldn't afford drugs, didn't matter if they were young or if they were on Medicare Part D, because Medicare Part D, according to Dr. Levine, did not solve the problem. She wanted to raise the issue that clinicians need to sit down with their patients and when they're writing out script, say, can you afford these drugs? What can you afford? So my question to you would be, I mean, did you ever do that? Do you ever do that?
Well, as a physician, you know, we don't think about cost enough. I think it's a great point. I mean, the first point is non-adherence is huge. And sometimes we call it compliance. Compliance sometimes puts the blame on the patient for stopping taking the medicine. But here, non-adherence means just not following through with the prescription. And we don't often think about cost as being a huge issue. You know, physicians don't spend enough time thinking about that. We need to talk to our patients, just like we talk to them about lifestyle modification, changing behaviors. We need to figure out whether cost is going to be a barrier to them taking an important, possibly life-saving medication. Often we are busy as a clinician writing a lot of prescriptions, trying to get them on the right thing, get the risk factors under control, and don't spend enough time talking about costs, which I think this study shows is a major issue for our patients today.
Now, one of the issues that Dr. Levine raised was that, that clinicians might be able to sit down and say, all right, here's a list of medications that we need to put you on. But these are the ones that are really important. Let's figure out a way that you can get those drugs. Let's figure out a way to get you those. Does that seem practical? Do you think that physicians can be trained to do that?
Well, I think physicians can be trained. I think the key is, you know, how do we prioritize things for our patients? I go back to lifestyle modification. When I give a patient a list of many things to do, patient sometimes gets frustrated and, you know, says, I can't do all this. So how do we do a stepwise approach? So in a stroke patient, we know there are key things like an antiplatelet, like a statin, and like probably antihypertensives or blood pressure control. We have to prioritize them and probably select the drugs that are effective as well as reasonably cost available for that patient and put cost into the equation.
Mm-hmm. I mean, I think that there's been some statements coming from the American Heart Association about this issue of cost, and I think you mentioned to me that there was even a survey done about the concerns about cost, and refresh me exactly.
We have done surveys, particularly around the time when we were looking at the Affordable Care Act, and looked at what were some of the biggest concerns of our patients out there. And actually costs comes up as one of the biggest concerns. And costs to pay their medications, costs to see their physician, costs to get preventative care services. And that's why the American Heart Association, following their principles, have been a big supporter of the Affordable Care Act, because there are parts of that legislation that will provide more preventative services and medication coverage for patients who really need them.
Mm-hmm. So you're going to stick with the fight supporting that as it goes through the courts?
We have stuck with it all along, and we stuck to our principles. And our principles are to reduce cardiovascular disease and stroke, and many of the provisions in the Affordable Care Act do that, including the preventative services, the increasing the different for uninsured, trying to get more people insured. I mean, this legislation has a lot of good things in it for cardiovascular disease and stroke patients that we will stand behind.
Mm-hmm. Well, I want to thank you, Dr. Sacco. It's always a pleasure to speak with the neurologist who is now president of the American Heart Association. But here at the International Stroke Conference in Los Angeles, I'm Peggy Peck for InFocus.